welcome back to the Oral Health Podcast. Karen and I are joined by two guests today, where we're going to talk a little bit about oral health and physical health, as well as mental health, who I'm going to let introduce themselves now. David, if you want to just introduce yourself first. Who are you? What do you do? Why are you here?
Okay, so my name's David Shiers. So I was a former GP in North Staffordshire. I was a mental health lead on an early intervention in psychosis program many years ago now. But mainly, and the reason I'm here is because I've been a caregiver to a daughter who was given a diagnosis of schizophrenia when she was 16, and Mary's now in her later 40s. And in fact, Mary has a complex set of problems which include diagnosis of learning disability and schizophrenia. But that's the hat I'm wearing today as a carer.
Mm-hmm. And Angela, what about yourself?
Yeah, I'm a registered learning disability nurse. I've been a manager here at the Larkins care home for nearly the past 4 years. The care home, we support females, adults with learning disabilities and additional complex needs, including dual diagnoses of learning disability, mental health, dementia, challenging behaviour, etc. And in addition to the management role, I'm also the clinical lead, and I also take the lead on oral hygiene and oral health.
Wow, okay. So you have like your own designated part of your role is oral health within the care home, which is interesting because I've not heard that before.
Really? No, I'm what we have champions of various, within various extended roles within the team.
Mm-hmm.
Yeah, and I happen to be the oral healthcare champion.
That's brilliant. So we'll come back to what your experience has been like working in that care setting in a moment, Angela. But David, do you want to just talk a little bit about a bit more about yourself and your experiences and what really it was that motivated you to raise awareness about physical and mental health things, particularly psychosis? I know that's your main remit from the things I've seen, but just if you want to expand a little bit more on that, that'd be great.
Yeah, well, I mean, the specific issue today is about oral health. And as a carer, with my wife, our eyes were opened about 6 years ago when Mary moved from previous care settings to the current one at the Larkins. And there's a sort of phrase it is that you don't know necessarily what good care looks like until you see it. So our previous experiences over many years was that we were sort of uneasy about what was being offered for Mary's oral health, but we didn't have that expectation, so we had a low expectation. And it was only when we moved on to the Larkins that we saw what good care looked like. Now, obviously, I'll let Angela describe what good care is, but that's what really struck us. When Mary moved to the Larkins, we suddenly appreciated good oral health. In terms of Mary and my involvement, Mary developed a psychosis when she was really quite young, when she was 16. And so we're talking late 90s, and at that time, the treatment was very institutional. She went into an asylum. She was given lots of very heavy-duty medication, and her physical health was totally neglected. So it's a fit young woman who spent 3 years in a very poor environment, taking very high doses of medicines, flattened by the medicines, and really, in a sense, forgotten by her friends. So that was Mary's really first experience of the impact of mental illness. And from that point on, she had lots of support requirements. She's been through a series of care settings, and all the time the sort of attention to physical health has been sort of disappointing from my point of view. In my other hat as a sort of ex-GP and a mental health lead, I was very conscious of the importance of physical health. Mm-hmm. And I always felt it was lacking, but this is something I really wanted to advocate for. So a lot of my working life has been spent advocating for improved physical health care for people who've got difficulties like my daughter. In terms of oral health, so as I say, I came to the Larkins with my daughter, not with a high expectation, and suddenly saw what very good care was, and that inspired me to get involved then with other groups of people who were also interested in the impact of mental illness and oral health. So that was the sort of the spur to do that, and I'll perhaps talk a little bit about that later, about that particular work. But picking up the bald facts of, you know, what people like my daughter can expect, they're likely to have 5 less teeth than their peers without mental illness. They're 3 times as likely to end up with no teeth. They have 4 times as much gum disease. They tend to present quite late with oral cancers potentially. So there's double the risk of late presentation with oral cancer. And also, interestingly, the rate of admission with a non-psychiatric illness to an acute hospital, general hospital, oral health crises are the 3rd commonest reason that people go into hospital. So that's a huge impact. But that's just sort of the physical side. The emotional side, of course, is that poor oral health affects you. So it's a 2-way relationship. Severe mental illness can be associated with dental problems, but also dental problems affect how you feel about yourself. They can affect really basic functions like chewing and talking and socializing, having a job. So they have big impacts on that. And then the 3rd connection is that poor oral health actually affects physical illnesses. So people like Mary also have much higher rates of diabetes and heart disease than their peers. They die earlier because of these diseases. Poor oral health actually interferes with those diseases too. And those diseases, particularly like diabetes, also affect your oral health. So there's a real vicious circle at play here.
I mean, like you say, it's just such a fundamental basic need, a human right, you know, to have your teeth clean. Like you say, it's difficult because within the mouth, your teeth, you know, you can get away with someone, you know, not having been cleaned, but if you've got long or dirty toenails or fingernails, it's very observable. So I honestly feel like it's such a privilege to work with somebody in such an up close and personal, almost intimate way to do, you know, to help them to, you know, do the oral hygiene tasks, you know, brushing their teeth, mouthwash, whatever. It's an opportunity to, you know, have a chat, to look into their eyes. For example, in the morning, you can be chatting about what the day ahead holds. You might have some music playing in the background. You know, you can actually set the tone for the day. And in the evening, you know, talking again through that process. There's no better way than, you know, drawing an end to the day and saying good night. So I personally feel it's a total privilege.
Yeah.
And I would be, I would be, you know, have something to say for carers who I felt if they didn't feel that they were able to do that and able to make the most of that interaction. Yeah, I wouldn't be too pleased.
Yeah. When the previous experience we've had, and it isn't just one setting, it's a series of settings, with the oral health had no priority at all. And one of the things that really distressed, particularly my wife actually, when she'd go into Mary's room and find the toothbrush was without bristles and completely caked with toothpaste. You look around at other residents and you'd realise that oral health was definitely not a priority in this home. And so you felt that you were pushing and complaining and being awkward. And that was a difference. When we came to the Larkins, we suddenly realised that actually it was quite legitimate. It was legitimate for us to be uneasy about this, but our expectations were set low. And I think it's now we've experienced good care. I think one of the challenges is how we raise expectations from people using services and their families and their carers on what they should expect. Because I think that's part of what can drive improvement. I don't have to push very hard in the Larkins. It's interesting that the CQC at the moment are running a campaign called Smiling Matters, which is to profile the NICE guidance that came out about 4 or 5 years ago on oral health in care homes. And the Larkins was actually profiled as an example of good practice. No, I didn't know that. I mean, we came here just, you know, very grateful. Mary's had lots of different experience, and this has been a great experience here. We hadn't appreciated just how good the oral health care is in the Larkins. I think when the CQC select this home as a place of good practice, then, you know, then maybe what you're hearing from Angela does give you insights into how care homes should what their ambition should be. And
absolutely. And I think that is something everybody should be striving for. And it's really comforting to know that there are some homes out there and some people out there that are, you know,
just take it
happy
seriously,
to do it. Yeah. I mean, the other thing that we found when we were looking at care homes, because we used to have an oral health educator, bless her, and she was the only one, worked in North Warwickshire, and she used to try and run a scheme with sort of championing oral health. And she found that if you were in a very big home, it was somebody's birthday every day. So every day people were getting cake and they weren't brushing their teeth. So we've got the double whammy of lots of sugar and no toothbrushing. So that was adding to the decay rate in these homes. So they were trying to swap out the nice treat, which is nice, but maybe not every day, and swapping it out for something else, an activity or something different. But we were kind of getting like more information on not only the neglect but also adding to the problem as well. So that was an interesting one to find out.
I mean, coming back then to the issue of medicines, medications. So quite a lot of people who've got complex needs, including learning disability, including certainly severe mental illness, will be taking antipsychotic medicines. There are a number of problems. Antipsychotic medicines have definitely stabilized Mary's mental health. So I'm very positive and absolutely about the benefits they bring, but they bring problems too. So they make you crave food. So from the moment Mary started taking these medicines, she craved food. They also give you a dry mouth. So the combination of dry mouth and craving food is potentially quite serious. And certainly in Mary's, looking back over Mary's time, access to fizzy, sugary drinks, that would be one thing I'd pick up very easily. That's what the medicines made you want to do. They made you crave food, they made you crave glucose, and they made you thirsty.
Yeah,
that's not just antipsychotic meds. A lot of psychiatric medications do this. The other problem with these meds is, you've got a combination of symptoms from the psychosis and the difficulties you have, also the side effects of the medicines. So then you have problems with accessing dental care, because that's the other thing we do know is this population don't access dental care, anything like as well as the general population. So you have what I'd call it an inverse care situation, that those people who need the care the most get the least.
And when you're talking about medications as well, we have a few interviews with the different pharmacists in London coming out later on in Smile Month, who said pretty much exactly the same thing. Of a lot of mental health medications have side effects that impact your mouth. Dry mouth is the most common, but also altered tastes and cravings and ulcers, and it comes with a laundry list of side effects. Some of the medications people get put on, but to still take them, and that if they are really problematic, they can find ways to work around it. Because at the end of the day, it's risk benefit, really, isn't it? Like, you need to, if that's making you better, then you need to keep up with it, but be aware
that's where
that
I think
comes with.
I think that's where Angela coming with clues, because I think those are the same problems that Mary's had right the way through the last 30 years. However, here they've been managed. So the issues of access to very sugary foods and drinks, and for some reason also accessing, I'm going to be interested to hear your thoughts about the sort of oral health care you provide, but also I'd like to mention the special care dentist, because that's been quite remarkable.
We have fabulous, we've built a fabulous relationship, if you like, with the local dentist, Richard. He's really got to know the ladies as well. The ladies have like an annual checkup, obviously, with Richard the dentist, and then 6 months later they'll see the hygienist, and obviously there are appointments in between. So some of our he one thing he does is he prescribes the fluoride toothpaste. For example, that goes on the MAR chart every day, every morning, every night. So staff are having to sign that they've supported the person with the teeth cleaning. The dentist, some of the ladies that we support here with neurodiversity and grave anxieties around going to visit the dentist. So we might use role play, social stories. gradually building that rapport with the dentist, you know, just going to the dentist without having the examination, building up that relationship till we get to the point where the ladies, you know, their fears are allayed and they'll happily go along with support from familiar staff. There's one lady who is unable to go to the practice, so Richard attends to her, you know, within her own home, and that works really well. But yeah, having that relationship with the dentist, you know, having it on record where adjustments are necessary, you know, whether a person needs, you know, more time, you know, like a double appointment. We can consider with the community nurse and GP involved as well, whether, you know, sort of anti-anxiety medications can be given, you know, like PRN, lorazepam for somebody who's extremely, you know, too anxious to have, for example, a treatment done. So there are, you know, and we can work to put best practice, best interests in place for those that need them. Mm-hmm. So that relationship with the dentist is absolutely key, and we're very fortunate here at the Larkins that we've got that relationship.
Yeah,
and we've
totally.
had that for a few years.
That makes a huge,
I believe it's quite
difference.
unique. Yeah.
Oh, unique. Yeah.
From other managers in other care homes elsewhere, that we are very fortunate in that respect.
Yeah.
Which is,
I think when I was on the helpline, we used to get lots of calls from care home managers, you know, can we get a dentist for our residents? And hugely difficult because of the way the NHS works now. It is very difficult, especially if you want someone to come and visit, which I would have thought would be much easier because you can do a fair few in the same visit. But it's the way the contracts work now. It makes it difficult. I know I take medication that dries my mouth out, and I've been trying this this toothpaste, and I'll have to tell you what it is, because my mouth, I cannot stop dribbling after using it. It creates so much saliva.
Really, Karen.
It's absolutely, it's all right. We're dental. It's fine. Honestly, I produce so much saliva that it's amazing. So I'll have to send you that tip, because it is great stuff.
I'd be really interested actually to know, while we're on the topic of dental visits for care home residents. So with them, let's talk a bit more about like daily routines, and I'd be really interested to know how you can encourage someone to take care of their mouth if they're having a bad day, if they don't want to, or because I imagine patience, I think, is the main thing that comes from a care setting, is you need to be patient with people. But
absolutely, yes.
What do you think is?
Well, if we can take back a few steps to a starting point, which might be that we support each resident to have an oral health assessment. This considers their ability to brush their own teeth effectively, the choice of brush, the paste they need, the flossing skills and mouthwash, and all of this information is included within each resident's person-centred support plan. And it's a really important document. It includes what the person can do for themselves and what support they need. It's got details of the dentist and the adjustments that are needed. Also details how we support each resident to choose and purchase their own toothbrush. And for example, we know, don't we, David, that Mary likes a medium bristle, pink and bendy toothbrush.
Yes, bendy.
And the devil is in the detail with these things.
Yeah.
So that starting point, you know, ascertaining what the individual can do. You know, we want to maximise their own independence, to raise their own self-esteem, and there's nothing better than seeing somebody taking pride in their own personal appearance.
Yeah.
And then we have a monthly oral health assessment. It's a form where me as the oral health champion, I look at, you know, hygiene. Are there any loose teeth, signs of decay? We observe the tongue and the lips. We ask about pain. We consider salivation. And it's like a checklist with a score, and if you reach a certain score, it's flagged up that there's something to be addressed, and then we'd contact the dentist for support. So we have that as a monthly tool alongside our audit. So within our, you know, structured monthly quality checks, we're actually looking at the toothbrush. You know, do they need a new one? You know, is it still effective? And we consider the effectiveness of the oral health support that's being given, and that any appointments have been made and attended. So there's various systems and we have an oral health policy in place, and that's influenced by the NICE guidelines, the NG48. So that's influenced our oral hygiene policy that we have here at the care home. And we also make sure that our staff team have the right skills and attributes to support residents with their oral health. And every member of staff does participate in an oral health training module within, which actually falls within the care certificate, which is a new thing, because that's a requirement, should be a requirement for all care and support staff to undertake that training. And then there's additional training that's available, you know, for each care home to put a member of staff through to become the oral health champion for the service. And the role of the oral health champion is it's quite varied. It's, you know, making sure that the policy is relevant, doing the monthly checks, looking at the audits, making sure appointments are arranged, carrying out the assessments, supporting and observing staff, you know, that watching them actually practically supporting the individual to see that they've got sort of the right values and attributes and personal traits that are required to support somebody in a kind and a caring and adequate way. So I do think often within, you know, staff meetings that we have, it's frequently on the agenda. We think about it, we communicate about, you know, about it, and it's well, it is literally always on the agenda of what we do here at the Larkins.
So, and from my point of view as a carer, I'm particularly thinking about how we used to feel about the previous settings. You know, to walk into, you know, to see a cupboard with a bristleless brush in, and a you know, caked with toothpaste, to actually have to negotiate yourself for a local primary care dentist to see Mary, which was always too fast, didn't work out well at all. It just felt as though we were pushing. It wasn't part of the home's policy. Now, what we've talked about today is oral health. If you was to talk about skincare or how, you know, the whole range of functions, this is a great home that does. So oral health is just one facet of what this home does very well. So I wouldn't like you to think this is the only thing that Larkins does is oral health, and everything else, believe me, the whole...
Not at all, not at all.
No, we can see it's not just oral health.
Sorry to butt in again. It's just, I think if you can get that very, almost a basic, you know, element of personal care right, then everything else should be right and good, you know. But if you can't get that basic, you know, task right, then, you know, gosh, goodness help us. It's not difficult to do.
No,
it just needs to be on the agenda. There needs to be a policy and processes, and it can flow quite easily. And we don't invest a whole heap of time, but it's there, you know, it's part
but
of
as the more you do it, I mean, it is, like I say, it's 2 minutes. It might take a little bit longer if you're cleaning somebody else's teeth, but everything you're saying is absolute music to our ears. I mean, this is absolutely, you know, I don't think I've ever heard.
You if she had the ability.
Yeah, I would.
And plop you in different counties and regions.
Yeah,
I'm sure.
I mean, we have put together, you know, a package for carers, for everybody to understand the importance. And it's okay putting it in the CQC guidelines and saying they've got to do that, but who's going to show somebody how to do it? Who's going to say, right, this is how we do it, rather than saying you've got to do it? Then you could be not doing it correctly. You could be, you know, and I think that is half of the problem, that you kind of skip the things you don't know about. You know, it's like I say, it's really refreshing. And yeah, I think residents are lucky.
Karen, I was so refreshed that I actually got quite cross. I said, well, why is it that Mary's had to wait such a long time?
Yeah.
But also I thought, well, what's happened to everyone else who are like Mary, who are not fortunate to be in a care home like this? So it motivated me to go and meet up with a group of primary care colleagues, mental health colleagues, and dental colleagues, and put in a very small bid against a program that's called Closing the Gap, run by University of York. So this is a UK research funded program. And for a small grant, we managed to run a series of meetings over COVID, and we all agreed on that this is a rights issue. The facts were actually quite simple facts, as what I started describing earlier. But actually, this was a health inequality, and that this population, for a whole host of reasons, are actually, it's not surprising they get the problems they get. And what should we do about it? So we generated then a consensus statement that we've called the Right to Smile. Oral Health Foundation, thank you, were very early adopters of or endorsers of this. And so that process generated a consensus statement, which is a political statement really about this being a health inequality that should be tackled. And we're targeting 3 main areas. We've developed 5-year targets with this consensus statement. So it'd be great to give a link to that at the end of the podcast.
Yes, absolutely.
But the three main themes were that you cannot have a physical health check that doesn't include oral health as a consideration. It's like you've not done it. If you want to do an adequate physical health check, you need to include oral health. So that's one element of it. Another element is about access, that this is a health inequality, this is a disability rights issue, that you should have extra help to access services where you're struggling. So that's covered by the Equalities Act of 2010. And this is a classic example where people need extra support to access dental care, where the reality is they're actually accessing it far less. So there's something about access. And obviously what Angela's described here is the sort of way, very imaginative way you can actually tackle that. And then the third big theme is about training and education. So, you think about it, mental health nurses get no training or very little training in physical health. It's unusual to get any training in oral health.
Yeah.
Primary care gets very little training in mental health, and certainly the combination of oral health and mental health, is a big gap. So there'll be relatively simple things that could be done about this, but at the moment there's very little training about this issue in the sort of key professions, the key places where people like us pitch up, asking for help. So one of the early wins has been that NHS England have agreed to include oral health now in their recommendations for a physical health check. So that's a huge step forward. And I'd like to think that this consensus statement and the little group we were in has influenced that. And then I take a step back and think, well, that's what happened to me because my daughter came to the Larkins, to a care home which gave good care. So there are some positive things that have happened out of this, apart from Mary getting superb care. I'm hoping others will not experience some of the things that Mary's had in the past.
And as well, like the link between oral and mental health, I completely agree, it is not explored enough, which is one of the reasons I was really keen to speak to you both. But specifically as well, like severe mental illnesses is talked about even less than that. Like we talk a lot about anxiety and phobias and the impacts that low mood can have on your oral health because you're less likely to want to do self-care, and we can talk about like the surface stuff because we don't have the knowledge to go any more advanced than that. But like there's a not insignificant proportion of the population that experiences severe mental illnesses and psychoses, and they're just as it's just as important for them.
Yeah. And there are real barriers. I mean, you think about it, if you're symptomatic, suspicious, uneasy, sleepy, sedated, can't concentrate, actually accessing dental care, let alone your normal routines of oral health self-care, but actually accessing dental care is very problematic. And
like
also,
you say, it's a vicious circle, isn't it? I mean, you don't want to clean your teeth, so then if you feel a bit lethargic and you're not really in the mood and nobody's pressing the issue, then you're more likely to have problems, which is then going to affect your mental health. And somebody who's got toothache who perhaps can't articulate that they've got toothache is a very difficult person to deal with, and they won't eat, they're not sleeping. It has such a massive knock on, and in some ways it's ill-diagnosed as well if they've got a dental problem. So one
and that's
can
right.
just help
and training I mean, Karen, did you have much training in terms of mental health, you know, as a dental practitioner?
No.
You know,
No.
so these are very simple things.
Phobics. We get training on dental
like
phobias.
a little bit on eating disorders.
A little bit on eating disorders, but but what I'm saying, Sophie, is that is because I've gone and sought that training. That isn't part of the qualification training. You don't really get, or certainly in my day, I can't talk about these days because it's a while since I qualified. It may have changed, but no, we kind of talk about when we've actually got the patient actually to the surgery, and you know, the things, and we don't really the training, that certainly the training when I did it doesn't go into mental health and the issues it can have.
Potentially some simple solutions to something that's actually, you know, really long overdue.
Yeah, I mean, when we do CPD, we do choose to do one of the recommendation is vulnerable. The vulnerable community, which obviously mental health will come under that umbrella. So the CPD that we have to do to remain registered does cover that section. So it is encouraged that we do training.
Yeah, I was just to say that I think one of the reasons why, for me personally, good oral hygiene and health has always been high on my agenda, is simply because in the end of the 1990s, when I completed my registered learning disability nursing, we had one lecture from a dentist who came in to talk about, you know, the importance of, you know, dental health and hygiene, which I think in its day was clearly really forward thinking. And I think that for me then sort of set the scene going forward, because the role, you know, of the registered learning disability nurse it's a very holistic role. And dental care being one of those things, I took from that, you know, the importance, the links that were clearly known then, you know, to health issues, you know, and inequalities. I've obviously taken that forward, haven't I, now? And I think that's why it's high on my agenda. And I do think it just highlights, doesn't it, the importance of training. As we've just said.
And that's not to mention primary care. Well, there you go. But you know, holistic care. I mean, it's you know, it's what we do. Primary care is about holistic care, because it's understanding that if someone has a dental problem, it affects everything. You know, and so there's no physical health without oral health. You know, and probably no mental health without physical health. So these are very interconnected issues, and it needs a holistic approach, and a very practical holistic approach too.
I can absolutely recall some really difficult situations where residents in the past have presented with, you know, a huge deterioration in their emotional well-being, and presenting with, it's been very challenging to the service provider. And then, you know, finding out somewhere along the line that, you know, yes, there's tooth decay. Someone happens to have a look or find out, and the tooth is extracted and the behaviour dissipates and disappears. I mean, you know, for those individuals that can't communicate, you know, pain or uncertain about the way they feel, you know, sensory issues, it's absolute key that we're making these regular checks on their behalf, you know, having a look at the mouth.
Yeah,
I guess a lot of that comes with knowing the person as well, right? Like if someone's been in the care home for a long time, you can spot when they might be feeling unwell, or when they might have an issue that they're not communicating. You get to learn their
absolutely, yes, picking up on their, you know, their non-verbals, their mood, their appearance. Yes, it's absolutely so helpful when you've got to know somebody so well.
Before we finish up, I just want to ask you both, if you can, you know, take your experiences and, you know, the years that you've dedicated to what you do and raising awareness and, you know, living and working with people close to you that are facing these issues all the time, if you could pass on any advice to either, say, someone that might be in a similar position to yourself, or just wants to look out for people around them, what would you say? What would your bit of advice be?
I think for me, it would be for managers in similar positions, you know, managers of care homes, for example, taking that opportunity to learn more about the importance, and just putting into place, you know, a good policy with good processes and systems, ensuring that their support staff within the team receive that training and education as well, and that there are tools in place, you know, to monitor all of that, and, you know, to take a very person-centered approach with each individual resident, and ascertain what they can do, what support they need, and just make sure those appointments are attended with a dentist, and consideration of, you know, obviously the diet and menus and reducing sugar and all of those aspects. It's not, you know, you've been very kind to me today, very complimentary. I don't really see it as something that is extraordinary. It really shouldn't be. And as I said before, it doesn't take all that much time and effort. Once you've got those few things in place, then it should flow, and monthly audit should check that it's flowing. And if it isn't, you go back, and it's like a circle of ensuring quality. And I think, as I said, it's such a basic human need, a fundamental right, and it's as important, if not more, than any other aspect of personal care.
Absolutely.
Well said. Well said.
Well said. Yeah.
Thank you.
What about yourself, David?
Yeah, well, I have spent the last 30 years really trying to raise expectations amongst people who use services, and their families, because that's, for me, is the thing that's troubled me most. It's, is it called the tyranny of low expectation? The sense that, you know, you lower your sights. This is a very complex issue. Having a member of your family with a severe mental illness and all that goes with it. It can end up lowering your expectation, and you settle for things which you shouldn't be settling for. And yet, until you see something like we've seen here, where you realise, well, what does good look like? So I suppose I still feel that my task is to try and raise expectations of people around me, that they should expect more from services. And so things like the right to smile, for me, is a way of trying to get a conversation going, but also to raise awareness. And if I can influence, you know, one other person, one other family, to say, no, this is my right, and there are some things that should be done about it, then I feel as though that can influence the system. Because ultimately, I think this is about, I think it's about how you influence the system. That's still my sort of main aspiration, I suppose.
Do you think people are getting it better than advocating for themselves and their family members than when you first started doing things like this?
Yeah, it's a good point. I think people are much more sensitive. I think psychiatric services are far more sensitive to physical health issues than they were, and I think that's, you know, cardiovascular disease and metabolic disease like diabetes are now much more on the radar of psychiatric services. I suppose the other thing I should add is that a lot of these conditions, their origins start very, very early. So Mary was 16 when she became ill. That was the point at which her physical health was put at risk. The general population would be 20 years later, but for Mary, those risks started at the age of 16. Early intervention services, which is where someone like Mary would present nowadays, are much more tuned to the physical health needs of the people they serve. So that's positive. Oral health, I still think, is a neglected area. It sort of falls between the gaps. So I think there's still work to be done about getting that conversation going. But, you know, it's positive. I do feel that getting this right early on is really critical. Once you've got advanced difficulties and diseases, it's really difficult to pull it back. So I still think there's a very important prevention aspect here. That's not to say that people of Mary's age don't require expert care like they're getting, but the possibilities of preventing disease, that's really important, and that's the opportunity you get with early intervention services. So that's my sort of personal target, is influencing healthcare, physical healthcare in early intervention services.
I mean, if you catch anything caught early, is much easier to treat. And obviously with any dental issues, the treatment's much more complex if it's more advanced, which makes it more difficult for the person who's having the treatment. And you know, part of it, I think, is also that you can see if somebody's got dirty hands or a dirty face. You have to be much closer to them to see if they've got dirty teeth, and maybe that is, you know, I mean, we've all seen the kids. I mean, mine Mine have been indoctrinated with dental things, so it's never been my kids. But yes, I've brushed my teeth. Yeah, I brush my teeth. And they haven't, because the toothbrush is dry or whatever. But, you know, it's that kind of thing. You can skip it because nobody can see, really. You get away with it if you're not feeling.
And if you've got other things to deal with, you know, if you're dealing with an acute illness, psychiatric illness, and you're in a difficult setting, I can understand how oral health might not be the priority at that moment. But you need help. I mean, that's very much the time when you do need professionals just to hold things for you, just to nudge you a little bit. Because boy, once you start that vicious, you know, that sort of vicious circle of decline, it's really difficult to pull it back.
Yeah, and
so I think the opportunities.
It's, you know, it's a couple of minutes twice a day that could stop all of these problems, or you know, at least ward them off for longer periods of time till they're, you know, people are older. But yeah, and I think that link is what we've got to get over to people. Catch it early and you'll help in the long run.
Okay, so I'm allowed a wish. My fantasy wish is
go on then.
that anyone attending a psychiatric clinic early on in the course of an illness should be given a toothbrush and a tube of high fluoride toothpaste.
I like that.
I think that would be a relatively cheap intervention.
Yeah.
It may also sensitize the practitioner to realise this is an important issue. So that would be my fantasy wish.
Let's make that happen, Karen.
Not an electric toothbrush. No.
Just maybe not. Electric.
It's funny, isn't it? Because we were looking a little while back, and some people with sensory issues actually prefer an electric toothbrush. Because they like the feeling of it. Some are very, very ultra sensitive and don't like it.
Not an agreement there, Karen.
Some people absolutely love the feeling of it. So it's often good to try. If somebody won't tolerate a manual toothbrush, try them with an electric, because they might like it. Flavourless toothpaste as well.
Absolutely.
Yeah. Flavourless toothpaste or apple toothpaste.
Bendy toothbrushes.
Bendy
toothbrushes. I had an advert through today for salted caramel flavoured toothpaste.
You can get red velvet.
Now there's a contradiction in terms, isn't it?
Yeah, that doesn't sound quite right, really.
No, not right.
It doesn't feel. You wouldn't feel fresh afterwards if I felt like I brushed my teeth with a cake. But you know, each to their own.
I'm sure you give it a go, Sophie.
I don't know. I'm attached to my peppermint. What can I say? We'll wrap up there then. It's been brilliant to talk to both of you. Like you said, David, I'll put information and links to all of the resources, including ones that I know you've done but haven't mentioned, because I've read them and I think they're great. So I'll put them all in the description area of the podcast. And
you see why I was so keen that you should meet Angela?
Yeah, definitely.
She's fantastic.
Definitely.
I'll be able to get that door today.
Oh wow. Yeah. But it's great that you find that just absolutely normal, and we're actually going, oh my gosh, Angela's amazing, Angela's amazing, because you are not.
So hopefully this will inspire other care homes
I hope
to think about this.
I
mean, is that possible that you can, you know, this is something we should make other care homes aware of?
Perhaps I could get some sponsorship and go around and tell them all. You want to influence, you know, a wider circle of people, don't you? Certainly up for that. So not just here in the care home, you know, I do influencing things outside. So,
excellent. Yeah.
Oh, well, I'm pleased that both of you were able to spend some time with Karen and I. I just have to edit out Karen, which is going to be tricky.
Oh,
so we'll know.